Good morning, everybody. It's John Clarkson here. We're here for next episode, if you like, of the Alumni Festival. And this particular webinar is called Generating Evidence for Public Health in the 21st Century, Building Interdisciplinary Approaches. Now, that is a bit of a mouthful, so Carol and I got to unpack that over the course of the next 45 minutes or so. But just before we do that, there's a chance for Q&A. We're not going to speak for the whole time. And if you have questions, please click the Q&A button at the bottom of the page and type your question. And we will do our best to get to as many questions as we possibly can at the end of our talk. And we are recording this event, so you can pick up and rerun it again later, should you wish to do so. And we'll remind you of where you can find that at the end. So that title, it is a bit of a mouthful, but what you have is you have an engineer and an epidemiologist. And we're going to introduce ourselves and say a bit about who we are and where we've come from and why we have the interest which has manifested itself as Cambridge Public Health. So, and then we're going to talk about one particular project called Healthy Growth as an illustration of the power of what we can do when we bring these different disciplines together. So I'll start out and introduce myself as the engineer. I had the extraordinary privilege of growing up down in the West Country and went to school in a cathedral school where my passions were music and math. And I spent many years just learning to play the horn and wonderful things about mathematics. And from there, I went straight to work for English Electric Valve Company. And I looked at things like camera tubes, and that big thing on the right is a klystron, and it's used for broadcasting TV. And I learned about the architectural properties of electronics and mechanical systems put together, and got interested in systems. At that point, I came to Trinity Hall and I studied engineering as a first degree and then stayed on to do a PhD. And my PhD was all about stepping motors, and in particular, trying to understand the torque speed characteristic of this little motor, and specifically why it had problems at the high speed end, why it didn't work. And 2 years later, I developed two equations. Well, the first one took a week. The other one took almost 2 years, that lower equation, to try and figure out why things didn't work. And I could plot the results. And ultimately, I was able to say, well, that red bit I was looking for, I now know what it is. I know where it is, and I know why the motor doesn't work. And again, there was an introduction into systems, how the electronics, the mechanical elements of the system work together. I then went to work for PA Consulting Group, just south of Cambridge. And that's when I really became an engineer. So amazing opportunities. And I was the project leader for developing the control system for naval training systems. So any naval personnel are trained to fight fire with computer controlled fire systems. And this is one of a unit of 3 installed around the UK, where if you put the right extinguishant on the flames, they decrease and you can put the fire out and you learn how to fight fires. I also was the safety officer on the original John Smith's widget beer to make sure we didn't kill people in developing that new beer product. And I did a lot of work in medical technology. And one of the projects I was involved in was putting a computer inside this discus inhaler so we could monitor its use in practice. And I guess what I learned through 7.5 years at PA is that engineering really is just two questions. How can we do it better? And what could possibly go wrong? And more than that, I guess what I learned is it's all about the process. It's the way in which we answer those questions that matters. So I came back to the university about 25 years ago, and just some of the things I've looked at, one of them is inclusive design. And it's that balance of the questions, but pretty much more the left-hand side. How do we do it better? How do we do it better when we're looking at diversity in the population where it's normal to be different? And how do you help somebody who is well used to using an old analog Roberts radio become in control of the digital version? How do you make that possible? How do you have to understand about people and the way they operate equipment? And we've developed things like gloves and glasses so that designers can start to experience some of the physical aspects of disability and what that should mean in terms of how they change their design. And just to give you one more recent example, we've been looking at these hero images, the images you see on websites when you want to buy things online. And this example shows the original Dove image on the left and the one we've created on the right. And we now have set the international standards for these hero images to make them more accessible. And actually, people sell more product if the image is clearer. Another passion I've had right from the start is healthcare design. And this is much more the balance of the two questions. And about 15 years ago, we worked for the then chief medical officer and looked at how design could assist in patient safety. And we looked at a systems approach. And the challenge here was that human beings make mistakes because the systems and processes they work in are poorly designed. So we were trying to sort of counter that and say, well, how would we design better systems and processes to take out mistakes? More recently, about 5 years ago, I ran a project with the Royal Academy of Engineering and the Royal College of Physicians and the Academy of Medical Sciences, where the exam question was really to work with the health and care professions to explore how engineers can add to current understanding and practice of engineering and quality improvement in healthcare design. And there was usually 2/3 clinicians and care providers in the room, 1/3 engineers, trying to unpack what this would mean. And we focused on the issue of systems, well known to healthcare. There's the waterproofing system, the plumbing system, the digestive system, and so on. And they understand the concept of systems. So we would focus on that. We also looked at design and this transformation from trying to understand the need to be able to define the problem before you then search for the solution. And we looked at risk as a double-ended challenge, not only trying to reduce the threat of accidents, but to learn how we would learn from the exceptional and really to shift this curve to the right to make the outcomes better. And the inclusive design came back into play. We looked at the people perspective, trying to look for the diversity in the patient, public population, and in the provider population. And all of that translated after many months into a set of questions we could ask if we were trying to improve something in health or care. And very much the questions on the right-hand side are trying to make us better understand the problem, and the questions on the left-hand side are much more about, well, what would the solution look like? And this was a novelty in health and care, and we've been developing that ever since, and thinking more about the process again of how would we do that. We need to understand the context, define the problem, develop the solution, collect the evidence. And we underpin that by trying to make the case for change, manage the plan for change. All of it about trying to agree that scope in the first place. And we've taken those ideas and developed them as a toolkit for improvement. So that's part of what I've done in the past. And for the future, it's still for me these two questions, getting that balance right. And my team in the engineering department, the Engineering Design Center, we focus on education, impact, and research. So for example, in the healthcare area, we are taking the systems approach and we are teaching it as part of a healthcare data master's course in Cambridge. We're developing a whole new master's program on healthcare innovation, where we bring this knowledge of systems thinking as well as technology into play. We also do a lot of work with the local healthcare trusts, and particularly we do a lot of work with Addenbrooke's and working on them with projects where our engineering thinking, our systems thinking can add value to what they're doing. And we now have a physical presence on the Addenbrooke site. So just opposite outpatients, we have an improvement lab and a technology lab. And this team is curious because they came together in about April last year, using our space to look at face mask design for safety in the sort of COVID environment. And actually, I've been working with these people ever since, having not met any of them, but they're using our space at Addenbrooke's. And the final thread is Cambridge Public Health. And it's really been that coming together of the engineering background that have this passion for health and care, and Carol's interest in public health, and how do we bring those two threads together? So at that point, to make more sense of the other half of the world, I'll hand over to Carol, who will talk about the epidemiologist.
Okay, so great to be able to do this session and the journey, and thanks, John, for introducing it so in such a lovely sort of narrative style. So I will give my own sense of how I came to be here, just very briefly. So again, it's a quick narrative, and Just very briefly, I come from North Norfolk. I went to a local grammar school, effectively a high school, which collected people from all around the rural area. And in the sixth form, and not many people went to university from my school, in fact, even though it was highly selective from the area. So it's a very interesting how things have changed dramatically across our life courses. I had access to the New Scientist in the school library, and in that, I really developed a passion for thinking about the environment. My father was a farmer, and actually, I used to sit on the top of one of those straw trailers that John showed with the precariousness. And well, if you imagine a couple of children on the top of that, that's what we used to do when I was a small. So I think that kind of really led me into understanding the context of the environment. And I was very, very attracted towards that area. But in fact, I had already really decided that I wanted to do medicine. And so when I was a medical undergraduate, I discovered epidemiology at the Royal Free Hospital, which is where I trained. And I wanted to divert into epidemiology because I really loved the idea of the trying to pull out what is causation and outcome, and particularly at that time with an environmental kind of perspective. But I was very well advised by mentors in London at the Royal Free to go away and become a proper doctor before I went into epidemiology, and to come back if I was still interested after I had I had done more training in medicine. So I did carry on into general medicine, and did my first research. At that time, I had an opportunity to be a doctor at amateur boxing, because we used to have to go to boxing. We were invited as junior doctors to go and be the doctor on the side of the ring in amateur boxing, and the police invited us, in fact. And so I said, yes, if we can do some research. So we did some research, which was about head injury or head hits to the head and blood and changes in the blood of enzymes that are released if the blood-brain barrier is compromised, which I had seen in research from Cambridge, which was about trying to assess the severity of head injuries, and thought, oh, that would be interesting to do that in boxing. So that research was published. So I got my first taste of research. And although that wasn't classical epidemiology, it was the sort of first the pathway to epidemiology. And then I went into neurology, and I really got the bug of neurology. And at the time, an epidemiology training opportunity came up. And where I was working was right next to the London School of Hygiene and Tropical Medicine. So somebody, a colleague, brokered a meeting with one of the most senior epidemiologists of the time, Geoffrey Rose, and he was incredibly welcoming. And he said, "Come, apply, come and do epidemiology, neuroepidemiology." So that's where I kind of had that motivation. And then my higher degree then focused on medical epidemiology, effectively focusing on brain aging. And that was very much motivated by wanting to understand the relationship between normality and abnormality in brain aging, and where dementia fitted within that. And in fact, that research has never stopped. I followed my husband to Cambridge and became embedded in the Cambridge Department of Community Medicine, as it was then, and became involved in teaching and pursued my own research, which was going out and interviewing people in the Fens, women aged between 17 and 79, and doing what might be called deep sort of phenotyping of people, then using the techniques that were available at the time. And that led on into population studies. And what that really taught me was that epidemiology is one thing, one part of our toolkit. And of course, it's had a lot of prominence recently. I used to say I was an epidemiologist or medical epidemiologist, and people say, what? I have something to do with skins. But everybody now knows what epidemiology is. But of course, it's more focused on the infectious disease epidemiology at present. But what's working in the Cambridge environment and setting up a master's in epidemiology, and we had a master's in public health being set up in the Cambridge department, which became community medicine and then on into public health and primary care, that you can't really do anything in isolation, that multidisciplinary work is absolutely critical. And that's where the work and the development of cross-disciplinary platforms working, really examining cohorts across time, and trying to understand aging from not just the brain aging, not just the dementia bit, but also in the context of whole life. And I'm going to just illustrate very, very briefly some of the research that I've been involved in. And this is in a way complementary to what John was saying, and in that we need the evidence base, the kind of grounded evidence from the population is complementary to thinking about what we need to do and all the design and the systems approaches that John has talked about. So I've been involved and had the privilege of leading multidisciplinary teams across the country and internationally in the field of dementia and brain aging for many decades now. And this is perhaps one of the most prominent set of findings from these studies. And the Cognitive Function and Aging Study, CFAS, was conducted in the early 90s and then again in 2010. And we used the same methods to examine dementia in the population, actually, and we looked at healthy aging as well. So it's we can look at a lot of different things when we develop cohort studies and population-based studies that are aimed at understanding health in the population. And the slide, or the figure that's sort of on to the front is the prevalence. That's the percentage of people who meet the study diagnostic criteria for dementia. So this is a population representative study conducted across the UK of people aged 65 and over. And the blue line is the earlier generation study conducted in the 1990s. And the red bars are the study conducted in the 2010s. And what you can see is that the proportion of people who meet dementia criteria in the population at different ages has gone down in the more recent generation. So this is not a follow-up study. This is new sampling in the same localities, holding the methods steady, including the way that we diagnosed dementia. We study diagnosis of dementia. And so this is a very, very dramatic finding in public health terms, that we can change dementia in the population, that there are things happening at societal level. And on the figure to the back is the incidence, that's the new occurrence of dementia, which also showed a 20% reduction across time, largely driven by a reduction in men. And this has happened in other high-income countries as well. So this is not just unique to the UK, and it's not just this study or those locations. So this is really important. And what it really shows is that we can change health in the population. We can change something which happens at the tail end of life, if you like. Most dementia is in the oldest old, as you can see from this, and it is vitally important that we understand it. Most of the benefit, most of the reduction is seen in areas with higher advantage. So people who are living with disadvantage across their life courses are at higher risk of dementia, as well as at higher risk of living a shorter time. So it's like a double whammy. So this is really, really important in terms of understanding how we think about a societal response to such important findings. We've had a lot of interest in the pathology of dementia and specific changes in the brain and specific subtypes of dementia during my career, with a heavy, heavy focus on Alzheimer's disease. So one of the things that we've been able to look at is the changes in the brain in relation to all sorts of different factors, including education and so on. But this slide is in relation to age. So we've taken classical pathologies, and this is just an illustration of two pathologies, atrophy and neuritic plaques in particular part of the brain. And it shows you what proportion of people die with that feature, atrophy, and whether they had dementia during life. And what you can see there is broadly the relationship of atrophy and whether you have dementia or no dementia is the same across the age groups. But for a classical pathology of Alzheimer's disease, it's very different. So what you see is a very substantial rise in the proportion of people who have neuritic plaques, which is a classical Alzheimer type pathology, with age, even if they die without dementia, and that the dementia people who are dying with dementia actually have less Alzheimer's, and the oldest have less Alzheimer's disease in their brain. This is really important if we're thinking about the implications of dementia in the population, and the fact that it's in the oldest old that we're seeing most dementia. That's where the societal challenge is. That if the pathologies aren't behaving in the same way as we age, then the suggestion that we have a single drug to address a specific protein that might make the plaques is very important, because we might medicate vast numbers of the population without them actually having any benefit in the longer term. So that's just another illustration of the types of research that we've done. And also looking at protection of the brain. So this speaks to the kind of public health and thinking across disciplines and across life course, that it's quite clear that education at a group level, at an individual level, of course, we're all at risk, but at a group level, that people who have higher levels of education express less dementia with Alzheimer type pathology, whatever the level of the pathology. And so those downward lines relate to the level of pathology, and then you can see by education, the more education they have, the smaller proportion of people express dementia during life. So there is by no means a one-to-one relationship of the pathology with a dementia in life. And this is really important for us to understand, the nature of the expression of disease in the population in relation to the underlying pathologies. So it's multidisciplinary research because it brings in all the biomedical as well as understanding the social context of individuals and their life experiences. So that's a kind of a key findings from those studies. And it fits into, this is evidence generation to try to feed the public health approaches to societal health and well-being. And it feeds into the primary prevention, secondary prevention, and tertiary prevention discussions. Where do we put our eggs? And I would argue we need to put them in all baskets: upstream for prevention, which is trying to sort of reduce all risk in the population and for individuals within the population. And secondary prevention is early detection. And tertiary prevention is trying to mitigate the impact of a condition once present. So supporting people with a condition and the carers, or in the case of dementia, around the person. Secondary prevention is where a lot of the eggs in the basket are at the moment in the way that we frame things in terms of investment. But from a public health perspective, which is about the organised efforts of society to improve health and well-being, we really need to have a balance across all those areas. And that's the excitement of having Cambridge Public Health, because we can bring together the different disciplines related to all of these different types of approach. And public health, of course, is very much about the individual within their context, and that's the right-hand figure there. So that's the sort of my journey into public health. And here's a quick history of what's happened in Cambridge, because of course there's been a lot of public health research in Cambridge, really starting with community genetics and ecology. It was human ecology originally in the 80s, and then became community medicine. But in 1993, a bespoke Institute of Public Health was set up with a building. And it was a partnership between the Medical Research Council, the NHS, or the Department of Health, and the university. And it created a kind of base for the powerhouse that you see now of public health across Cambridge. And that institute was in the clinical school, and it grew many units and groups who are now who've got fantastic research programs and with different focuses such as cardiovascular medicine, epidemiology, diabetes and obesity, and physical activity and nutrition, and also biostatistics. So that has been a fantastic development in Cambridge over the last decades. I was the director of the Institute of Public Health from 2008 to 2008. And during that time, John and I became leaders for the Public Health at Cambridge network, which started to build the cross-disciplinary networks across the whole of the university. And in 2020, Cambridge Public Health was created as an interdisciplinary centre. And so this is bringing in the strengths that we had created in the Institute, and also the strengths that were developed in the network. So that's the kind of history of the development of Cambridge Public Health. And we have had a great deal of discussion about the way that we shape this interdisciplinary centre with town halls and so on. And these research pillars are what has emerged, and cross-cutting themes around which our activities are being built. And each of these have leads across the university, and with all schools, or pretty well all schools represented. And they're also very linked to the sustainability development goals. So we have life course and aging, health inequalities, this is vital, as I've mentioned, global health, sustainability, and public mental health. And cross-cutting themes are vital in terms of the methodological angles that we bring. And there are huge strengths in different bits of these across the university, such as in economics, health economics, and sort of the macro public health type economics, ethics, legal and social implications is really very important. Technology and systems, and evidence synthesis, and data science and artificial intelligence. And each of these will be interacting into the future. So we're hoping that individuals will want to engage with the Cambridge Public Health, and we invite folk to get in touch with us on this space to discuss things with us. So that's Cambridge Public Health in terms of its research. And then the activities are research, capacity building, and impact. And what we want to do is really signpost what's happening in the university, because there's so much going on. And make it visible so that folk can see how you might, say, build a career in public health, or how your research itself might be enhanced by having some exposure to public health. So we're hoping to build a visible pipeline to help people navigate their way around public health research, and also facilitate the interdisciplinary learning and interdisciplinary, say, masters, for example, as well as generate leaders in research and leaders who will then go out into the different sectors in society and bringing that population health and wellbeing thinking and that multidisciplinary thinking into the way that they work. And then, of course, impact, building partnerships with the new landscape in public health and with the commercial sector and internationally as well, so that to be available to try to provide advice and potential for training and so on, to, again, navigating and also making our research more visible and having to have more impact. So that's Cambridge Public Health. I'm going to hand back to John now. And
I now should have control again. And I talk about a particular project that came to Carol and I at the beginning of this year. And the project's called Reform for Resilience. And they had this challenge that they created this entity, it was an East of England MP, to help shape new models, metrics, and practical policy reforms to help leaders in the public and private sectors deliver the changes needed for healthier growth. And what they'd been thinking about was this idea that you have health, you have the environment, and you have the economy. And how could they work together so that you could develop the economy and improve health, but also not do things of damage to the environment? And I, as an engineer, started drawing pictures at this point and trying to figure out what's going on, that we might have things that perturb any one of those three, the health, the environment, and the economy, which could have an impact on healthy growth. But I've spent long enough thinking about systems to realize that actually what really matters here is that those individual entities of the health, environment, and economy interact themselves. And we need to understand and better understand how those interactions take place. So that initial figure of hexagons looks a bit strange until you replace the big arrows with the interfaces. And I very deliberately said, I think we need to focus on the interfaces as much as we might focus on the core elements themselves. And then if you kick health, well, changes can ripple from health through to the environment that might affect healthy growth. And it's more complicated system of systems that we might have expected, but you need to understand what the interfaces are up to understand what happens to the whole. My team have been looking at this with Carol's team, say, well, what might these perturbations be? And there's a series of stresses that might happen. It might simply be uncertainty. It might be planned change, or it might be the sort of shock of something like a pandemic. And we want to understand, well, how does this system work in response to these changes, and what resilience can we build into it? And we spent a long time then thinking about resilience. And the other half of the research I didn't tell you about that I've been doing has been about complex systems in the engineering sector. I've worked with Rolls-Royce jet engines, Jaguar Land Rover, and we look at the complexity of physical systems and their resilience. And we ended up, after lots of thinking, with a definition that said resilience is the process by which health, economic, and environmental systems can face change and shocks in such a way that they evolve and innovate together to continue to deliver healthy growth for the population. So that's the definition of resilience that came out of much think about, well, what is resilience? Well, what is resilience? Well, resilience, if you look at it, has its origins in biosystems as much as it does in engineering. But what you find is that there is some agreement that there are elements of resilience like adaptability and robustness that you build into the system, and it responds to the changes and shocks that come upon it. And there are other elements of resilience that come from flexibility, the ability to change, and agility, how rapidly you can change. And these are properties of resilience, and you need to think about all of them as you continue to design the system to make it more resilient. And then there's the process that wraps around that, that you might anticipate what might happen in the future for your system. And as things happen, you watch it accommodate and respond to those changes. You have to study it and learn it, and then see how you transform the system to make it more resilient. And you go round and round this cycle. It seems like such obvious stuff, but it took a lot of time and effort to really think through what does resilience mean. And we've come up with what we've called the Cambridge model of resilience for this particular challenge of healthy growth, the system of interest in the middle, the properties of resilience, and then the process of resilience to continue to deliver something that has resilience. And then we switch to the other half of it and say, well, how would we know how well we're doing? How would we measure performance of healthy environment economics and of the interfaces and of healthy growth? And this steps right across much more into Carol's domain. And if we focus, for example, on health and its impact on healthy growth, how might we come up with an index for health, which contributes to healthy growth? Now, there might be a number of indicators which we can measure, which if we had knowledge of those indicators, we can infer a value for the index. And each one of those might be based on a whole bunch of metrics. But we may only be able to measure certain things out of all the metrics that might be possible. And this is where Carol and the team have to reassure me that if you can measure enough things, the indicators and the index that you can derive from that are almost invariant to exactly what you measure. And that comes from the sort of epidemiology side, outside of my domain, but shows that there are ways in which we could come up with an index, which if put all together and we look at the health of the interfaces as well as the key elements, we might be able to propose a metric for healthy growth. And if we get the mechanics of that right, it could be applied on a regional basis, Asia, North America, Europe. It might be applied at a country level for comparison, or even at a city level. How well does the city perform in terms of healthy growth, or at a business level? And each one of those levels, how you interpret the health and who you're thinking about in terms of health, what you term to be the environment, the economic elements, and their interface, it depends on what level you're looking at. And we're still partway into this project. We have a model, we have a framework, we're now looking at those indices. I think what it says is when you come back to that initial definition of resilience, it is a process. We have to learn how continuously to deliver resilience. But I've added the line at the bottom because I think this encapsulates what Cambridge Public Health is about, that designing the indices to deliver resilience requires a range of skills which can be found in Cambridge Public Health. And I think this project has shown us more than anything else that bringing together the engineers and systems thinking with those with a more traditional background in public health is enormously powerful. and has been recognised by our partners in Reform for Resilience across the globe as a real strength of the understanding required to solve this particular challenge. So this particular point, I'm going to stop sharing the slides and we can open up to the questions that have been sent in to us. And the first one, I think, is a really interesting question, which talks about how do we respond to the divergence of need, providing a solution that works for individuals or small groups. And that's a really interesting challenge in how that works in health and care, because my own background in inclusive design, what we're trying to do is to make solutions and products and services available to as many people as possible. And if you go beyond inclusive design, you'd be into assistive technology. And if I translate those thoughts into health and care and public health, it also crosses over with resilience, because we have to accept then the difference between the pathway we might prescribe and the individual journeys that people might make. And there may be many variations on those journeys. But I've had conversations with folk in palliative care where we said, look, what are the core principles that must be applied in a particular part of care? And what's the acceptable variation that tailors what we're trying to deliver to the individual? So I think there is this duality of trying to design for the population, but trying to adapt to the individual. So it is a form of resilience in a way, but seeing it in both those ways helps you come up with something that is fundamental to what you deliver, that in product terms, it's a radio that everybody can use, as opposed to saying, look, we have to individualize everything. So Carol, I'm sure you have an answer to this too.
Yes, well, I suppose it's the perfect illustration of the individual patient and the population as well. You know, that's, you could say they've got different needs, but in fact, what we have as when we're an individual patient is a set of needs which can be defined. It may vary. Some things will be invariant and some things will vary. And then the same thing applies to population. So we've got kind of the variation on both levels, but we've also got the tension between, do you have an approach? And the NHS is very, very individually focused. And our public health systems are more local authorities, say public health and local authorities is more at the whole population level. And I think in a way, it's a false dichotomy, but in resource limited environments, which we all are now, and many of our populations live in extremely resource limited environments, not just globally, but also locally, that we need to understand how we can invest best for those different elements. And we really do need to ensure we kind of employ our evidence base. So we've shown this change across generations in dementia prevalence, which means that there's something that happened in the investment post-war into our whole populations that has made us more resilient, made our brains more resilient to dementia. But that doesn't mean that we won't get dementia. So we still need the dementia care. So it's really important that we understand at a public health level or population level the balance between those, and try not to have them as adversarial, to focus on the tensions between them, but actually the synergy and the balance. And I think that's how we have to do it, but it has to be done very much in discussion with society, and how we develop our systems to work to, as it were, bring the evidence that we generate, and to generate evidence appropriate to each of those parts of society. So it sort of comes back to that systems thinking.
In the design world, one of the things we do is we focus on personas. So we develop a set of fictitious people who are real in a sense, but we encourage designers or system improvers to understand that diversity and to test conceptually what they're trying to create against that range of different people. And it's really important. And I think that systems approach opens up the mind to say, oh, I've thought of an answer. Yeah, but do you really understand the need that sits behind the problem we haven't articulated yet? So it's always that encouragement to go back to the beginning and say, look, who are the stakeholders? What needs do they have? How do we translate that into a challenge or a problem we're trying to solve? And how do we then solve it for as many people as possible? And it's really important to be able to do that. But it is a challenge. There is a dilemma. But I think making that dilemma explicit raises the chances that you can resolve it. Carol, I think the next comment and question really is for you.
Yeah, I was just going to say, I mean, I think COVID has really illustrated that point about stakeholders really very strongly, and it's coming through in our own research calls for funding as well, in that we really, really need to make sure that we understand our populations and have the stakeholders, the full stakeholders present and helping to co-produce what are solutions. But so, and that's where the adaptation and the generalizability sort of needs to be brought to bear, because there are some things that are generalizable to all populations and all people, and there are other things which must be adapted in order for them to work, and they may not work in particular populations, and you can only find that out by talking with people and understanding their experiences. Yeah, thanks. So it's just about the COVID, which I think has been incredibly important in highlighting inequalities and our different sectors of society. So there's a question about education. So thank you, Jürgen, for your kind words. Yes, well, it's still not really fully understood, and there's an enormous amount of work going on reserve. So you can think about it as being from conception onwards, basically. But have you got a healthy brain that's developing with a healthy early life? And then, how do these things that happen in adolescence and the reshaping and modulating of the brain across adolescence contribute to what might be a resilience in older age? And I think what we need to do in research is try to understand how to optimize brain health at each of those life stages, because in midlife, then you accrue the disorders and the risks that are associated with a higher risk of dementia. What was really interesting about our that neuropathology finding that I showed was that people who were dying with higher education didn't have lower changes in their brain. They had the same. They weren't protected from the pathology. They had less dementia, and it was another fact. There were other factors. So some of the research suggests that it's density of synapses and so on. But there are quite a few ideas about why generationally we're at lower risk of dementia, and that could be bigger brains because we're actually bigger sizes as well. So there's all sorts of reasons why we might have optimized our brains better at given ages. There's another one here, isn't there? Implications for policy and practice. I think I've covered that a little bit with the life course. I think, again, it's something that the aging and life course research pillar, will over time, I hope, develop. But the sense of bringing the evidence base to policy and impact for each life stage, and look and think, what evidence do we have about what can be done for pregnant mothers and fathers and parents, and in order to optimize entry into the world, and then optimize, as I say, try to reduce the negativities that happen across the life course, so that we reach each life transition with a better health. Because there's no doubt that if you reach 65 without too many health conditions and with a reasonable state of health, your aging will be better than somebody who reaches that life stage with a whole load of conditions and multimorbidity, and inequalities plays a very big part in that. So that's so lots of implications for policy and practice.
So there's another question then about when developing systems using the multidisciplinary approach. How do we get the voice of the affected population groups to help co-create the solution? And I think the questions I showed you were developed with practitioners and with users in the room as well. And the reason we came up with questions is it's a very accessible way of asking people what they think about the challenge, or what is the challenge, what are the needs, but also their ideas for solutions. So I think it's key to listen to people if they think they have ideas for solutions, but it's key to ask questions of them to make sure you really understand the underlying need and the particular challenge. And what I find is that some users, some folk who are the recipients, if you like, of what you're trying to do, are inspired in terms of the solutions they can think of, but may or may not have the practical skills to deliver them. So you're trying to get that voice and engage with them before you develop the solution, but also during the process, but also accepting there may be others who are more skilled in developing the product or the service. But having that sanity check all the way through, and the ultimate users are in the room and will tell you what will not work, as well as what they think might delight them, is really important. And I think, I just use the word delight, I think you ideally want to delight people with the service you provide. It's that sense of you've gone beyond their expectations. And I've used that word in workshops talking about palliative care. What would delight people in palliative care? And it seems like the words shouldn't go together. But as soon as you use that language, people will tell you all the things that they hoped might happen, as well as all the things that went terribly wrong, which you want to learn from as well. So I think, for me, it's not just about solutions, nor is it just about the problem. It's about the insights that describe the need of the various stakeholders or players in the system that you really want to understand particularly well. So you've got to get people in right up front and not be afraid of going and finding people you think are missing as you go through the process. You discover somebody you should have been talking to, go and find them, get them engaged. So for me, it's engagement throughout the whole process and making sure you do the right thing. And Carol's heard this story before, but I talk about being in the fog, and I particularly about being comfortable in the fog. As somebody trying to improve a system, you have to be comfortable not understanding or not quite knowing what's going on. You keep asking questions with the people who own part of that system. And the purpose is eventually when the fog clears, you want everybody to be facing in the same direction with that same sense of the scope, the same sense of the challenge, and a sense of direction as to how to move forward. You can't do that without the end users of the system engaged in that process.
So I think definition of end user there. So from a public health perspective, I'd say that the end users are all, in terms of the research and evidence base and generating the right evidence base, goes from national policy, legislation, understanding the political system, right through to engaging with local communities. And I'll just, so Brian has asked about local health service and national population epidemiology service. Yes, well, the health and wellbeing boards in England, of course, it's different in different parts of the country, are aimed at really understanding and integrating the sort of population health. And there's something called population health management now in the new landscape of the NHS and local authorities. And I think it is really important to bring the epidemiological skills and public health that gestalt to those discussions, because otherwise what we have done so much over the last decades for all sorts of reasons is create lots of silos. We've created silos for individuals. So if you might be treated for diabetes, hypertension, bone disease or whatever, and you have multimorbidity, and all the evidence base has been created on people with one condition, not lots of them, and probably younger as well. So we haven't integrated, and we need to do the same thing for individuals, and we need to do the same thing for localities, and also at national level to understand how policies interact with each other. So that goes back to that systems picture. If you sort of change something in one place, things will change elsewhere as well. So I'm hopeful that the discussions that are going on, and Cambridge Public Health wants to engage with local, regional, national, international. So working with our local partners in the NHS and local authorities, who hope we can help be part of the productive discussions, helping to generate better services more. It won't be us doing it, but trying to sort of support that development as an optimistic thing. I know things seem quite challenging at the moment, but it's
One final comment to pick up on too, Jürgen. If you want copies of slides or anybody else, just email us. I'm sure we can make the slides available to you. And I think that's the end of the questions. So thank you very much for engaging and sending in those questions. It's been a pleasure for both of us to be here to talk about what we're doing and how the engineering and the epidemiologists have come together. And historically too, we didn't mention it, that Carol and I have co-supervised a PhD student in the past, and that's an extraordinary way to bring two academics together from very different disciplines, and we learn together through the challenges the student has of trying to learn from an engineer and an epidemiologist. And I really hope as Cambridge moves forward, we set up many more of these interdisciplinary centres where we come out of our comfort zone. We do things that are actually rather more important than just sitting in the engineering department, and we do things for the benefit of the public and the population. So thank you very much for being here.